Hello all, welcome back. Today we are discussing about breast, and these are the topics that are given in the syllabus: Mastalgia, nipple discharge, breast mass approach, breast mass in pregnancy, benign breast disorders, proliferative and non-proliferative, breast abscess, mastitis, breast cancer screening, and breast cancer per se. So we'll walk through the breast anatomy and further detail. So breast is a modified sweat gland and it is developing along the milk line. This is what the milk line is. And it can develop anywhere along the milk line. So along the milk line you also can see some accessory breast tissue or accessory nipple. When there are more than the usual two nipple, it's called polythelia. Okay, and it happens along the milk line. And the structure of the breast has lobules and ducts, and they are lined by two layers of epithelium, which is one the luminal cell layer and the other is myoepithelial cell layer. Why this is important? Because the myoepithelial cell layer is a contractile layer and it is usually absent in cancerous tissue. Because cancerous tissue is abnormal, it may not have the two cell layer. So when you differentiate between an intraductal papilloma and the papillary carcinoma, the difference is that the carcinoma lack the two cell layer. Okay. So this is the milk line along which the breast tissue develops, extending from the axilla to the pubis and external genitalia. The normal breast anatomy, it has connective tissue as well as the duct and the glands. So resting against the rib and the pectoral muscles. So this is the adipose tissue or fat tissue. Then we have the lobules. Okay, the lobules are here and duct is here. Okay, and this is one unit, the lobule and duct. And those duct finally form a bigger duct, which is the lactiferous duct, opens into the nipple. Okay, this is a picture which I added. It can help you understand where the usual breast masses or inflammatory conditions are seen. So here we have the stroma, and this is the terminal duct lobular unit. Okay, with a duct and a lobule. So this is the lobule and this is the duct. Around it is the stroma, the connective tissue. And they all come together into forming a major duct, and then there is a lactiferous sinus which is opening into the nipple. So the fibroadenoma, phyllodes, tumor and all are seen in the stroma. Fibroadenoma is benign, again phyllodes is benign condition. So that is in the stroma. Now the terminal duct lobular unit. There you can see the fibrocystic changes, the ductal carcinoma in situ, lobular carcinoma in situ, and ductal carcinoma, invasive ductal carcinoma and lobular carcinoma. Then around the nipple and behind the nipple, you can see intraductal papilloma, abscess or mastitis, and Paget's disease. Paget's disease is nothing but the ductal carcinoma in situ has grown beyond its usual site and it has grown towards a nipple. That is Paget's disease. And usually there is scarring around the nipple and all. Okay, like an eczematous change around the nipple. So that is ductal carcinoma in situ, which is grown towards a nipple. So these are the usual site of different breast masses or inflammatory conditions. Now coming to mastalgia. What is mastalgia? It's breast pain. It can be cyclic or non-cyclic. When it is cyclic, it's usually benign. Okay, so it is moderate to severe pain, and it can be bilateral, it can be diffuse, it can also be unilateral. And it is cyclic because it is in accordance with the menstrual cycle, usually in the luteal phase. It is resolving with the menses. Okay, it is happening with the luteal phase. When it menses starts, it stops. Usually it's more than 7 days. It's in the premenopausal age group in the 3rd and 4th decade. There is no specific hormonal associations which is implicated so far. The premenstrual breast tenderness is a normal physiological response. It is usually 2 to 3 days before the onset of menses, and mild to moderate bilateral swelling and tenderness as well as tenderness be there. Okay, so when it is cyclical mastalgia, it is usually benign. You can just reassure the patient. It's a self-limiting condition. It usually stops when the menses begins. So you have to see if the breast pain is cyclic or non-cyclic. Coming to non-cyclic, it's usually unilateral and in a specific quadrant. It has no relation to the menstrual cycle, usually in a postmenopausal female. So for breast cancer also, age is one of the biggest risk factor. As you age, the incidence of breast cancer increases. So in postmenopausal female, if there is a non-cyclic mastalgia, it can be alarming. In the 4th to 5th decade, 31% of breast pain is non-cyclic. It can be idiopathic sometimes. There can be a tender cyst, a periductal mastitis, stretching of Cooper's ligament, can be trauma, sclerosing adenosis, Mondor's disease, which is superficial thrombophlebitis, and there is a cord-like structure. I'll show the picture later. And it can also be cancer. So you have to get alarmed. You have to investigate the patient. If needed, you have to go for after the clinical examination, you have to go for imaging, and if needed, if there is suspicion, you have to go for also histopathology or cytologic examination. So that was about mastalgia. Coming to nipple discharge. Nipple discharge can be a hint to different things happening in the breast. So if it is white, clear or cloudy, it can be milk during breastfeeding. It can be galactoria, hypothyroidism, prolactinoma. If it's yellow, it can be pus, like in infection, hormonal fluctuations. If it's green, brown, or black, it's duct ectasia and intraductal papilloma. If it's red, pink, or bloody, it can be again intraductal papilloma or breast cancer. So if it's bloody discharge, you have to get alarmed again. So green, brown, or black, think it as duct ectasia, usually in a postmenopausal female. Now we'll talk about the inflammatory conditions of breast. What is acute mastitis? It is inflammation of breast, usually in a breastfeeding female, associated with staph aureus. So it is spreading from the mouth of the baby as the baby is sucking. The staph aureus, which is a usual commensal in the baby, comes to the breast. If there is a crack in the breast, it can get into the breast and cause inflammation. So you have to continue breastfeeding. If there is acute mastitis, you have to continue breastfeeding and get dichloroxacillin for the bacteria. It may progress to abscess, wherein you have to do an IND. For any abscess, it is incision drainage followed by antibiotic. Then periductal mastitis. Periductal mastitis means it is a mass in the subareolar region. It is predominant in smokers and vitamin A deficiency individuals. And there is squamous metaplasia of lactiferous duct. Squamous metaplasia of lactiferous duct, but it is a benign condition. It's an inflammatory condition. There is mass in the subareolar region. There can also be nipple retraction. So always think that nipple retraction has to get you alarmed and think of cancer, but there are benign conditions also causing nipple retraction. One is periductal mastitis. So this is an image of periductal mastitis. You can clearly see there is an inverted nipple and there is a mass in the subareolar region. Then mammary duct ectasia. As mentioned, it's a green-brown nipple discharge. There is inflammation with dilatation of the subareolar duct, usually in a multiparous postmenopausal women. So in a postmenopausal women, when you see a breast mass, it has to get you alarmed. You have to investigate for ruling out breast cancer, because breast cancer is increasing with increasing of age. But there are benign conditions also happening in postmenopausal women. One is mammary duct ectasia. It's a chronic inflammation with plasma cell. Then fat necrosis or traumatic fat necrosis. Usually there is a history of trauma, but they would not come and tell you that I had this trauma and afterwards I saw this mass. The trauma could be trivial according to them, like they would not have any pain or anything incidental, anything just after that incident, but maybe sometime later they find a mass and they get anxious. So there is a mass, there is calcification on mammography. So calcification also one of the sign that you look for, to suspect cancer. But calcification again can be benign, like in fat necrosis. So it is necrotic fat with calcification and giant cells. Now coming to breast masses. So that was inflammatory conditions. We talked about breast uh, pain or mastalgia and as well as nipple discharge. Now coming to mass. So breast mass, we usually do a triple examination. One is clinical, okay. The other one is imaging, like mammography or ultrasonography. Ultrasonography usually in young patients, because of dense tissue, we cannot delineate so much in mammography, so we go for an ultrasonography. But if it is 30 years or older, we always prefer mammography. And then there is biopsy or histopathologic examination or a cytology like FNAC. So if there is a breast mass, first take a history and perform clinical examination. If examination suggests no mass, you have to repeat clinical examination in near future, like 2 to 3 months. If there is indeterminate lesion, in young patients go for ultrasonography, in older patients go for mammography. Then if there is a suspicious mass, you have to go for both mammography and a biopsy. Now we'll talk about the benign conditions and the breast cancer. Benign and fibrocystic changes. Usually the highest density of breast tissue in any normal individual also is there in the upper outer quadrant. That is why usual benign as well as cancerous conditions are also more common in upper outer quadrant. Okay. So benign conditions are usually in premenopausal women. There is a blue dome appearance of the breast, blue dome appearance. There is no increased risk of cancer, even with apocrine metaplasia. But there are increased risk of cancer if the biopsy is showing ductal hyperplasia, sclerosing adenosis, which also shows calcification. Like we mentioned, calcification was seen in fat necrosis, which is a benign condition. Sclerosing adenosis, which is benign, but there is increased risk of cancer, and atypical hyperplasia. So ductal hyperplasia, atypical hyperplasia, and sclerosing adenosis can predispose to cancer or increase risk of cancer. In intraductal papilloma, there is bloody nipple discharge in a premenopausal women. So again, bloody nipple discharge, usually think of breast cancer, but in a postmenopausal women. In premenopausal women, usually the benign conditions are more common than the cancerous condition or malignant condition. So bloody nipple discharge, usually seen in cancerous condition, but intraductal papilloma, a benign condition, can also present with bloody nipple discharge. Or like duct ectasia, it can cause like a brownish discharge. So how do you differentiate, like I mentioned, intraductal papilloma and a papillary carcinoma? So usual thing has a 2-layer of cell, okay, that is myoepithelial cell along with the luminal cell. But this cancerous cell lacks myoepithelial cell. So this is an intraductal papilloma, a single intraductal papilloma. Okay, inside the duct there is a benign lesion. Then fibroadenoma, which is a most common tumor in a premenopausal women. So in a premenopausal women, there is a painless mass, and they are more mobile. Okay, they are mobile and they are marble-like. It's called a breast mouse because it is highly mobile. Think of fibroadenoma. Okay, this is a histological picture which is showing a slit-like compressed duct with a collagenous stroma containing blunt spindle cells. Okay, so I told the fibroadenoma was seen in the stroma. Okay, fibroepithelial cells surrounded by a relatively hypocellular stroma. So just a picture to differentiate between fibrocystic changes and fibroadenoma. So fibroadenoma is usually painless. It's well circumscribed, highly mobile, round mass in a premenopausal woman. It's benign solid tumor containing glandular and fibrous tissue. Core biopsy may be recommended, can be followed clinically or surgically excised. Fibrocystic changes, most common benign condition of the breast. It may be painful. Needle aspiration demonstrates straw-colored or green fluid. Okay, so that is fibrocystic changes. So straw-colored fluid. There can be pain. Okay, so that is fibrocystic changes and fibroadenoma. Now coming to Phyllodes tumor. Phyllodes means leaf-like projections. It's usually in a postmenopausal women. So postmenopausal women also can have benign conditions like ductictasia. They can have Phyllodes tumor. Okay, so Phyllodes tumor is a benign condition. It's a very slow growing and has a good prognosis. It can be treated by mastectomy. It's characterized by large polygonal cell with abundant cytoplasm and lymphoid infiltration. Large polygonal cells with abundant cytoplasm and lymphoid infiltration in a leaf-like pattern. That's called Phyllodes tumor. So coming to breast cancer is the most common cancer in women excluding skin and second most common cancer cause of cancer mortality, first being lung. And the majority of breast cancer, 99% breast cancer, are seen in female. Female gender is one of the risk factor for breast cancer. But 1% seen in male are usually associated with BRCA2 or Klinefelter. Klinefelter also have gynecomastia that can predispose to breast cancer. And it's usually invasive ductal carcinoma. So breast cancer can be in situ carcinoma or invasive carcinoma. In situ can be ductal or lobular. Ductal can again be comedo type or non-comedo type. Comedo is more aggressive than non-comedo. Non-comedo are cribriform, micropapillary, papillary or solid. Lobular do not have much histological variation. Invasive can again be tubular, ductal lobular, invasive lobular, infiltrating ductal, mucinous or colloid, medullary and inflammatory, which is one of the worst prognosis. I added this picture just to show the difference between multifocal and multicentric. Just as you can see, this is the axillary tail. Okay, so this is the upper outer quadrant, which is the usual site of all the benign as well as the cancerous condition, because that is where highest density of breast tissue is there. So multifocal means more than one tumor in the same quadrant. So okay, that is multifocal. This means in different quadrant. This is multicentric. Why this is important? Because the treatment modality can change. If it's a very small tumor, okay, which is multifocal, not multicentric, which is multifocal. Say we have two lesions which are 1 centimeters in same quadrant, that is multifocal. We can still go for a breast conservation surgery, right? But if we have a multicentric, which is again small, but since it is involving different quadrants, we may have to go for a even more aggressive surgery. Okay, so that is the difference. Now, what are the risk factors of breast cancer? One being female gender, 99% are seen in female gender, and age. It increases with increasing of age. Early menarche and late menopause, that is prolonged estrogen exposure, just like we say in endometrial carcinoma, estrogen exposure. That's why also OCPs increase the risk of this breast cancer. OCP increases the risk of both breast cancer and endometrial cancer. It decreases the risk of vaginal cancer and ovarian cancer and cervical cancer. Then obesity. Obesity again, because fat has the aromatase enzyme can increase the estrogen exposure. That's why obesity also predisposes. Then atypical hyperplasia, ductal hyperplasia like we told, sclerosing adenosis, and first degree relative with breast cancer or familial cancer syndrome like BRCA1, P53 and all. Now coming to ductal carcinoma in situ, like we told, comedotype is high grade cell with necrosis. It's more aggressive than non-comedotype. Okay, so this is low grade, this is intermediate grade, and this is high grade. And like I told, calcification in breast can be seen in benign conditions like fat necrosis and sclerosing adenosis. Sclerosing adenosis can also predispose to cancer. And ductal carcinoma in situ. Paget's disease is nothing but DCIS, that is ductal carcinoma in situ, which extend up to the skin of the nipple. There can be ulceration and erythema and crusting on the surface of the nipple. Okay, like an eczematous change. Okay, there are Paget cells within the surface of the epithelium of the nipple. So this is actually the underlying ductal carcinoma in situ. So when there is an eczematous, this may be the only finding. Why this is important is this may be the only finding that the patient finds. There is ulceration, there is erythema, there can be crusting on the surface of the nipple. You have to think of an underlying cancer because there can be an underlying ductal carcinoma in situ which has grown up to the nipple. Okay, and the extension of malignant cells via the lactiferous duct. That is Paget's disease. Coming to invasive ductal carcinoma, it's the most common type of invasive carcinoma, invasive breast carcinoma. There can be dimpling of skin and retraction of nipple. And the types are tubular, which is having a good prognosis, mucinous usually in elderly. Inflammatory carcinoma, I told it's a worst prognosis. There can be erythematous and swollen changes on the skin, and it's a clinico-pathologic diagnosis. What is a clinico-pathologic diagnosis? You have to clinically see the signs of inflammation and pathologically see evidence of cancer. Only then you can call it an inflammatory carcinoma, and it has a very poor prognosis. Then medullary carcinoma, which is increased, has an increased propensity in people with BRCA1 mutation. So that is invasive ductal carcinoma. Okay, and medullary tumor have intense surrounding lymphoid reaction. They may be poorly differentiated. They have a favorable prognosis, okay, compared to other invasive cancer. And like I told, it has high propensity in BRCA1 mutation, and usually it's a hormone receptor negative. We also have seen Paget's disease. It is large faculated intradermoid cell arising from ductal carcinoma in situ. Okay, that is thought to have grown along the duct to the nipple. So when you see crusting around the nipple, eczematous changes, always think of an underlying cancer and work up for it. Lobular carcinoma in situ, there can be no mass or no calcification. It can be an incidental finding. Usually the cells are discohesive. Discohesive means usually the tumor cells, since they are growing so much, they tend to, form a cluster and be very much close to each other. But the cells are very much separate because they lack E-cadherin molecule. Okay, so they are discohesive. This is what we call discohesive. Okay, the cells are separate from each other. It can be multifocal. Multifocal means, say, in the same quadrant itself, you can have more than one lesion. It can be bilateral. You give tamoxifen and close follow-up. It has low risk of progression to invasive carcinoma. This is lobular carcinoma in situ. Then invasive lobular carcinoma or infiltrating lobular carcinoma. It has a characteristic single file or Indian file arrangement of stromal infiltration by the tumor cells with very little tendency to gland formation. So this is called the Indian file pattern of the cells. See, this is called Indian file pattern. Individual tumors are round and regular with very little pleomorphism and infrequent mitosis. Here also you can see the cells are like very discrete because we told that lobular carcinoma, the cells lack E-cadherin molecule, so they're very discohesive. So in the infiltrating lobular carcinoma, we have Indian file pattern. Okay, so infiltrating lobular cancers have Indian file arrangement. There is high incidence of multifocality and bilaterality with lobular cancer. They are
they have a greater tendency to be hormone sensitive. Like for medullary, we told they have a low tendency to be um, hormone sensitive. It was a ductal carcinoma variant. This is an lobular carcinoma variant, which is an infiltrating lobular cancer, which has Indian file arrangement of cell, and it is usually hormone sensitive, multifocal, and bilateral. Then there is inflammatory breast cancer. This is inflammatory breast cancer. I told it's a clinical pathologic diagnosis. There is clear evidence of erythema, edema, and inflammatory changes around the nipple and over the breast. It's a very aggressive form, very poor prognosis, characterized by intradermal lymphatic spread of tumor. A word on Mondus, it's a superficial thrombophlebitis seen as a cord over the breast. Okay, so there was benign and malignant conditions of the breast. Now we'll come to the cytology. So there is a three-step approach to breast mass. One is a clinical, the other being imaging, and cytology or histopathology. So FNAC, how do you report a breast mass? It is C1 to C5. C1 means inadequate. Okay, there is no inadequate specimen, you can't comment on it. C2 is clearly benign. C3 means probably benign, which means there is still a chance that it could be malignant. You can follow up in a short interval like 3 to 6 months, or you can directly go for another modality like repeat FNAC or a biopsy. C4 is suspicious or favorable malignancy. You have to confirm that it is malignant, and you have to uh, start treatment as soon as possible. C5 is clearly malignant, go for the treatment. Now we'll discuss a bit on the staging and the prognostic indicators. So the best prognostic indicator in breast cancer is number of positive axillary node. According to AJCC, 1 to 3 positive node is N1, 4 to 9 is N2, 10 or more is N3. Okay, and when there is a node positive cancer, usually give a chemotherapy, neoadjuvant chemo, and you do axillary dissection. When you do axillary dissection, the levels of lymph node is that is lateral to the pectoralis minor. So pectoralis minor is here, um, the reference, and lateral to pectoralis minor. So remember it like the ones that are reached first. That is level 1. Behind the pectoralis minor is level 2, and medial to pectoralis minor is level 3. So this is levels of lymph node. But this N1, N2, N3 is the involvement of lymph node and in the staging of cancer. Those are different things. I just mentioned it so that you know. Okay. And also ipsilateral supraclavicular lymph node. It is stage 3C and not 4. Okay. In the same side, if there is a supraclavicular lymph node, it's only stage 3 and not 4. Okay. So we'll just see that. Okay, so the staging is TNM staging. The T staging, the in situ means TCIS, cell CIS, and paged nipple, which is nothing but DCIS, which is extended up to the nipple. T1 micro is 0.1 centimeter, T1A is 0.5 centimeter, T1B is 0.5 to 1 centimeter, T1C is 1 to 2 centimeter. So remember, T1 is up to 2 centimeter. Okay. T2 is 2 to 5 centimeter. T3 is more than 5 centimeter. Now T4 again is for A, B, C, D. A is, so it is extending. Once it has increased in size, it is extending anteriorly and posteriorly. Think it like that. So T4A is extension to the chest wall. It does not include pectoralis muscle invasion only. It include extension to the chest wall. T4B, there is ulceration, ipsilateral skin nodule, or skin edema, including pudy orange appearance. So first it has gone behind, then it has come forward, and there are skin changes like ulceration and pudy orange appearance. T4C is both the extension to chest wall and the skin changes. T4D is the worst cancer, that is inflammatory carcinoma. Then end staging, we told N1 is 1 to 3, N2 is 4 to 9, N3 is more than 10, including supraclavicular. It is N3C, not stage 4. It's because N3 is 3C. Okay, this is an important point. Supraclavicular lymph node is 3C, not 4. It's not a metastatic or systemic disease. Now, what we do for the cancer can be told like a carcinoma in situ, a localized cancer, or loco-regionally advanced cancer, or a metastatic cancer. Now, when do we give a neoadjuvant chemo? Neoadjuvant chemo is given for a loco-regionally advanced, which is a tumor more than 5 centimeter, more than 4 axillary lymph node, which is N2 disease, or a tumor more than 5 centimeter. Okay, so that means it's a very big lesion. You give neoadjuvant chemo to make surgery possible, so you have to reduce the tumor size. So after the neoadjuvant chemo, the tumor size may become reduced. That is why you give a neoadjuvant chemo. And when do you do a sentinel lymph node biopsy? We'll come to that later. What are the indications of sentinel lymph node, and why is it done? So once you give a neoadjuvant chemo, you go for surgery. So the treatment modalities are surgery, chemo, radiotherapy, which is usually post-surgery, and hormonal therapy for ERPR positive and HER2 positive tumor. So the surgical approaches are mainly breast conservation surgery, or radical mastectomy surgery along with lymph node dissection or axillary dissection. So breast conservation surgery you can do when the excision is possible, if it is only unifocal or multifocal within 5 centimeter. Okay, we have told about multifocal and multicentric. Multicentric means in different quadrants, and multifocal means in the same quadrant, different lesions. If it's within 5 centimeter, you can still go for breast conservation, or rectal carcinoma in situ less than 4 centimeter. Okay, again for localized cancer also you can do if the excision is possible with good cosmetic result, and the margin can be excised. For loco region, you usually go for mastectomy. You can't usually go for breast conservation treatment, because even after neoadjuvant, if this tumor size is reducing, your treatment modality will depend on the initial size of the tumor, not the later size. Suppose if you have a 6 centimeter lesion, you give neoadjuvant, it reduced to 3 centimeter. Your treatment modality will not depend on the 3 centimeter size. It depends on the initial size. So don't get confused with the neoadjuvant. Neoadjuvant, you are doing that so the surgery becomes possible and easier. You are not doing that so that you can conserve the breast and the cosmetic appearance. Okay. So that is the treatment. The treatment: surgery, chemo. Chemo, you told it's for large lesions or nodal positive lesions. Then radiotherapy and hormonal therapy. Surgical approaches are total or simple mastectomy, total mastectomy with axillary clearance, modified radical mastectomy, which has different approach like Patty, Scanlon, or Auchincloss, radical mastectomy or Halsted radical mastectomy, wherein you are not conserving anything, you are removing everything. We'll talk about the difference between modified and radical mastectomy later. Conservative breast surgery is a wide local excision, that is the tumor along with the wide margin is excised. Okay, tumor along with the wide margin is excised. Lumpectomy means the excision of that lump. Quadrantectomy means if it's upper outer quadrant, you are excising the whole quadrant. Toilet mastectomy is like that's usually a palliative procedure when you can't do a surgery and you can't, or for metastatic diseases, if you don't justify doing a surgery and reducing the tumor burden, you can do a toilet mastectomy or skin sparing or keyhole mastectomy. These are different surgical approaches. This is the difference between radical mastectomy and modified radical mastectomy. So in both, you are taking away the breast nipple areola complex. Okay, that is taken even in simple mastectomy. And you're taking pectoral fascia in modified radical mastectomy. But in radical mastectomy, you're taking both pectoralis major and minor. But in modified radical, you're preserving the muscles as much as possible. If pectoralis minor has to be taken, you take. Otherwise, you preserve. Then levels of axillary lymph nodes. All the axillary lymph node, because it's a total axillary dissection. Like I told, level 1, 2, 3. 1 is lateral to the pectoralis minor, 2 is behind, and 3 is medial to the pectoralis minor. During radical mastectomy, cephalic vein is ligated. Now, when we are giving chemotherapy, usually for small, less than 1 centimeter, with a pathologically non-negative, we are not giving chemo. Radiation and hormonal therapy is indicated. Hormonal therapy according to the ERPR and F2 status. Partial breast irradiation can be offered if there is, though there is no current randomized status, you show the best modality of treatment. Then for more than 1 centimeter, all invasive cancer, as well as for node positive cancer, you give chemotherapy. Okay, so for the less than 1 centimeter node negative, you can usually spare them from chemotherapy. All others, you're giving chemotherapy. Radiotherapy is required whenever breast conserving surgery is undertaken. Okay, and tamoxifen is given for all if their ERPR status is not non or positive, you're giving tamoxifen. We'll come to the hormonal therapy later. Now for metastasis, bone metastasis is the most common distant metastasis for breast cancer. They are typically osteolytic lesions and can be treated with bisphosphonates, which inhibit bone demineralization, and they reduce pathological fracture frequency and need for radiation. So for breast cancer, metastatic disease in bone, you give bisphosphonates. Hormonal therapy usually act on the estrogen pathway in some way or the other. PR is again an ER induced gene. Okay, so usual drugs are mainly focusing on the estrogen receptor. The classes are selective estrogen receptor modulator, which are tamoxifen, which is the earliest and the gold standard treatment for for all the patient. But in postmenopausal age group, we may go for aromatase inhibitor like letrozole and anastrozole or exemestane. Then steroidal anti-estrogen, that is fulvestrant. Then there are other drugs like androgens, fluoxymesterone, progestin like medroxyprogesterone acetate and megestrol, LHRH agonists like leuprolide and goserelin, and gland ablation like ovarian, pituitary, and adrenal to focus on the axis and the hormonal axis or high dose estrogens. Okay, so there was hormonal therapy. Mainly we give tamoxifen or we go for aromatase inhibitor in postmenopausal female. Now a word on sentinel lymph node biopsy. So what is sentinel lymph node biopsy? So we find a tumor. We have diagnosed the breast cancer. We have classified it into a different stage, or we have prepared for the treatment. But we don't know whether the lymph node is involved or not. Okay, so when we don't know the lymph node is involved or not, maybe during surgery or before surgery, we have to find out whether there is lymph node involvement to decide on whether axillary nodal dissection has to be taken or not. We do a sentinel lymph node biopsy, usually with a dye like methylene blue, isosulfan blue, or a radio tracer. Okay, like technetium. So, what are the indications for sentinel lymph node biopsy? That is, sentinel lymph node means first lymph node that is draining the tumor. So if we are injecting the dye to the tumor and then we are tracing whether the dye has reached the first lymph node, then we have to take the lymph nodes, otherwise we can spare. So that is indicated for T1 or T2 up to 5 centimeter tumors, possibly T3 that is more than 5 centimeter. Clinically not negative. If it is not positive, we are not. There is no need for sentinel lymph node biopsy, because sentinel lymph node biopsy is to rule out whether there is lymph node involvement, female or male, unicentric or multicentric. DCI is when mastectomy is planned or when high risk features exist. Possible after prior breast surgery, possible after neoadjuvant chemotherapy. Limited clinically not positive disease after neoadjuvant with favorable response. We can go for again sentinel lymph node. It is not recommended for T4 tumors and inflammatory breast cancer. Inflammatory because it is a very poor prognosis. You have to take away the lymph node. Uh, you have to do a modified radical mastectomy and do a radiation and everything, because the prognosis is very poor. So the treatment is aggressive. So you don't. There is no point in doing sentinel lymph node. Clinically positive also you don't do without neoadjuvant chemo or recurrent axillary disease. More than limited nodal involvement, like several level 1-2 nodes, or involvement beyond level 1-2. For prior axillary surgery also, no point in doing sentinel lymph node. Pregnancy before week 30 also, you don't do a sentinel lymph node biopsy. So tumor is identified with ultrasound. The breast area is numbed with lidocaine. Then the dyes are injected. They travel to the lymph nodes. The lymphoscintigraphy shows which lymph node contains tumor drainage. The anesthesia is administered. Lymph nodes with the most dye are removed and sent to lab to check for the tumor cells. So that was sentinel lymph node biopsy. Now about breast cancer screening. Usually start from the age of 40 up to almost 69 years, as according to their health status and overall favorable status. Usually done yearly or every 2 years with a mammography. Okay, newer guidelines in UAE states that the women should have opportunity to begin screening if they decide from 40. From 45 they can go for yearly mammogram if they have a high risk, or they can also opt for 2 yearly mammogram. With age 55 we can transition to again every other year, depending on the preference. Age 55 plus they can continue to have regular mammogram as long as they are in good health. In short, you can say that the screening start from age 40 up to 69. Okay, and they can go for uh, yearly or 2 yearly mammography, one yearly or 2 yearly. Okay, so every 1 to 2 years. So that was with mammography. Now, who needs a genetic testing? Like we told, BRCA1, BRCA2, P53, all can predispose to breast cancer. So what is the 1, 2, 3 rule for hereditary breast and ovarian cancer? Who needs genetic testing? So one diagnosis in patient or first or second degree relative, that is breast cancer at the age less than 50, ovarian cancer at any age, triple negative cancer at less than 60, male breast cancer at any age. That is, if the patient is having a first degree, second degree relative, or in the patient itself, if we are seeing breast cancer less than 50 years, ovarian cancer at any age, triple negative cancer at less than 60 years, male breast cancer, and metastatic prostatic cancer at any age, or their ethnic Ashkenazi Jew descent, with breast, ovarian, pancreatic, or two aggressive prostatic cancer at any age. Non-mutation carrier for breast cancer susceptibility gene. That is one or two diagnoses in a patient or family member with first diagnosis made at less than 50 years. That is primary breast cancer. We're not talking about metastatic, primary. Two relatives diagnosed with breast cancer, one at age less than 50. Then three diagnoses, that is breast, ovarian, pancreatic, or aggressive prostatic cancer in any combination on the same side of family at any age. If there is 3 diagnosis, you can again go for genetic testing. What is the need for genetic testing? Because if the genetic testing shows that they are positive for BRCA1, BRCA2, they have a high predisposition to breast cancer, they can opt for bilateral mastectomy along with bilateral salpingophorectomy. Now, after the surgery, they can opt for breast implant with the tissue expansion breast implant or the muscle flap implant like a thoracodorsal artery perforator implant, latissimus dorsi, deep inferior epigastric perforator. There are so many muscle flaps available. Okay, so these are some of the perforators. Muscle flaps available. What are the complications of this breast implant surgery? They the implant usually form a capsule around it by the body mechanism, immune mechanism. That capsule can go for contracture. You have to then go for a capsulectomy or a capsulotomy. It can get infected. There can be an implant rupture or an implant associated, breast implant associated anaplastic large cell lymphoma. Okay, so that can be lymphoma also. It is rare, but it can be there. Now, word on breast cancer in pregnancy. Uh, in short, breast cancer in pregnancy is treated the same as breast cancer during other times. The guidelines and all remains the same. There are a few changes like ultrasound is a first line imaging modality used rather than mammo. Surgery can be performed at any time during pregnancy. Recommended method for sentinel lymph node localization is with technetium 99 and radiation, trastuzumab, tamoxifen. They are contraindicated and only given during the postpartum period. So if you find a tumor, you categorize that. You do the surgery during pregnancy itself, but radiation is started only after pregnancy. Or trastuzumab if HER2 positive started after pregnancy. Trastuzumab can cause cardiotoxicity in any individual. Tamoxifen, again for ERPR positive, started only after uh, delivery. Chemotherapy is contraindicated in the first trimester. Anthracycline based can be safely given in the second and third trimester but should be stopped 3 to 4 weeks before delivery. Dosing should be similar to that in non-pregnant based on the body surface area. Prognosis again in breast cancer appears to be the same as in non-pregnant if standard therapy is given. The first trimester, discuss about pregnancy termination. Go for a mastectomy or an axillary resection. Chemotherapy during the second trimester. Radiotherapy, hormone therapy, postpartum. If you find in the second trimester, again mastectomy or segmentectomy and axillary dissection, neoadjuvant chemo and surgery postpartum. Third trimester, mastectomy or segmentectomy, axillary dissection, and adjuvant treatment postpartum. What are the predictive factors to response to treatment? The status of the receptor, ERPR. ERPR positive tumors are more have a more favorable prognosis. HER2 neo positive can be given like trastuzumab. Tamoxifen is usually given in all patients. Aromatase inhibitors is most effective in postmenopausal. HER2 is a cell surface growth factor receptor. Okay, anti-Herceptin is trastuzumab. It has a cardiotoxic effect in individuals, and triple negative has a worse prognosis. Again, inflammatory carcinoma has poor prognosis. Okay, these are some of the prognostic indicators. So that's all. Thank you.